Hello everyone, my name is Lindsay Rehack. I am a medical surgical nurse. I work at MedStar Franklin Square Medical Center, and I'm also a graduate student at Notre Dame of Maryland University. And so today I'm going to share with you my knowledge about neurological disorders and how to care for patients suffering acute neurological conditions like traumatic brain injuries and spinal cord injuries. We're going to talk about the age-related changes that influence the care of patients with acute neurological diseases. We are going to evaluate our signs and symptoms of both traumatic brain injuries and our spinal cord injuries, as well as brain tumors. We're going to look at the labs and the diagnostic tests that we use for these patients, and we're going to prioritize, right? There are a lot of acute emergencies that arise when a patient has a traumatic brain injury or a spinal cord injury that we as nurses need to be attuned to. So we are going to take into account special considerations that attend holistically to the patient that's experienced one of these injuries, because they're going to have long-term downstream effects. Bring back your A&P, your anatomy and physiology related to the neurologic system function. I have a slide here that gives you a really good overview of each lobe and what they do and how they function. Remember, our frontal lobe, that's integral to our personality. And if it's impaired, we could have changes in our behaviors. We can become distracted, impulsive. And then we have our parietal lobe, which is usually involved, right back here, involved in our touch and visual perception, as well as knowing our right side from our left side and being able to distinguish, where we are in our environment, how we relate to our environment. We then have our occipital lobe, which is primarily associated with visual ability as well as color perception. Our temporal lobe, we know it's key in our intellect and being able to process information, especially what we're hearing, and then making sense of language and then translating that into our behaviors, as well as some of our visual perception, but mainly it's your parietal and occipital lobe. And then we also have our brainstem, which plays a huge role in our autonomic nervous system, right? Our heart rate, our swallowing, our reflexes, a lot of them stem from the brainstem. And then our cerebellum. This is involved with our voluntary movements, balance, and muscle tone. So if you have someone that's falling over all over the place, they can't coordinate their movements, they may have some type of disruption in their processing ability in their cerebellum, or they may have a tumor in their cerebellum. So these slides right here provide you a good overview of what the meninges look like, the different layers of the brain. Remember, you have your DAP, your dura mater, arachnoid matter, and then your pia mater. And then to the right, we also have our cross-section of our spinal cord and what these tracts look like. Remember, there are 31 spinal nerves that are all connected to this central spinal cord, and then they stem out. We have the anterior and posterior tracts that are responsible for our motor and sensory input, and then information that goes out to the periphery from the spinal cord. And then this slide here gives you a good breakdown of the nervous system, the divisions of the nervous system. So as we previously stated, we have our central nervous system, which, as you know, is the brain and spinal cord. And then the peripheral nervous system stems off of that spinal cord and consists of the motor and the sensory neurons. Our motor neurons is basically control of our muscles and our glands, and then our sensory neurons that provides sensory input and output to our organs as well as our tissues. From there, the motor neurons differentiate into the somatic nervous system, which controls our voluntary movements, and the autonomic nervous system, which controls our involuntary responses. So these are our fight or flight systems, right? The sympathetic division is our fight or flight, and our parasympathetic is the rest or digest, which will come into play here when we get into spinal cord injury. So our anatomy of the nervous system, mainly the brain, is composed of cerebrospinal fluid, brain tissue, which again is made up of neurons, right? And then we also have a blood supply. Okay, so we have 2 internal carotid arteries and 2 vertebral arteries that supply the area in the brain. And then we have what's called the blood-brain barrier, which is a separation between that blood supply, the brain tissue, and the CSF. Okay. So remember, your skull is a very tight enclosed space. And so when there's an increase in pressure in one of these areas, whether it's the area of blood supply or it's the brain tissue or it's the CSF, if there's too much of one of those things, we can have some issues. We can have swelling in the brain. We can have cerebral edema that results in increased intracranial pressure. And we'll get into what that kind of looks like in your patient. So you're probably remembering from your anatomy and physiology class the different functions of the areas of the brain and the different cortexes, and how you have this motor cortex that controls your voluntary movements, and then the sensory cortex. It's important to remember that the different areas of the brain, depending on what's going on neurologically as far as damage is concerned, is what you're going to see come to your unit. Depending on where that injury is in the brain or along the cortex, you would expect to see deficits in motor or sensory function. Delving a little bit more into the autonomic nervous system, this is what regulates our activities of our internal organs, like our heart, lungs, blood vessels, digestive organs, and glands. A lot of this action goes unnoticed. It's autonomic. It's not something that we necessarily have control over. When we find ourselves being chased by a bear or in stressful situations, we kick into this fight or flight mode, right? Our sympathetic nervous system kicks in. Whereas when we are, after we've consumed a large meal, we're ready to rest, there's no stressful situations going on around us, the parasympathetic nervous system kicks in, and that kind of allows us to rest and digest or relax. These 2 systems will be extremely important when we get into spinal cord injury, because we actually lose the ability to regulate and provide negative feedback to these systems. So they kind of go haywire. When you have a patient who presents with a traumatic brain injury, you're probably most familiar with what? A concussion, maybe? You know, as a child, or maybe when you played contact sports. So when we're caring for patients with neurologic trauma, we think about injuries that occur to our scalp, skull, or actual brain tissue. Brain injuries, particularly traumatic brain injuries, are the most common cause of death from trauma in the US. Usually it's going to affect patients that are males between 15 and 24 years of age, because they're more likely to engage in high-risk behaviors. So not wearing a seatbelt, playing contact sports, engaging in activities that could cause them to fall and hit their heads, diving into a pool. So it's very important to keep this population in mind. And then when you think about older adult, they have deficits in vision, sensory losses, balance issues that are falling all of the time and maybe falling and hitting their heads, they're at increased risk. Patients with traumatic brain injuries often have very long-lasting chronic comorbidities, as well as neuroendocrine abnormalities, psychiatric diseases, and chronic pain. So the best approach to a head injury is to focus on prevention, right? If we can prevent this from happening, that is the most important factor. We can also have spinal cord injuries that occur as a result of the same types of events that cause traumatic brain injuries. So motor vehicle accidents, falls, sports-related trauma and collisions, spinal cord lesions, and edema. So if the patient has a tumor, we can have tumors not only in our brain, but resting and compressing on our spinal cord. We can also have spinal fractures, which are very common, and we'll talk about them. And then spinal surgeries that can cause swelling and edema that cause decreased oxygenated blood flow to the spinal cord, which we'll talk more about. So what happens when we experience a traumatic brain injury? There are 2 types of injuries that result from a traumatic brain injury. The first is a primary injury, and this is the consequence of direct injury, direct contact to the head during that instant of initial injury. So it's when you first, hit your head on the bottom of the pool. And then we also have the secondary injury. This is damage that evolves over a certain amount of time, usually a couple of days, 24 to 72 hours after that initial injury. Your patient gets hit, and then what happens? The inflammatory response begins in the body, just like whenever you hit your elbow on something or you hit your knee on something, right? You have some swelling, you have some bruising. The same thing happens in your brain. So after that initial injury, this damage starts to evolve, and it leads to swelling that eventually causes hypoxia and decreased oxygenated blood flow to that part of the brain. This is a vicious cycle. Okay, so I want you to keep in mind the 4 H's that just keep kind of superimposing themselves on one another. So we have hypoxia, hypercapnia, hypotension, which is systemic, and then hypertension, which is intracranial, and we'll discuss why in just a second. So thinking about the pathophys, we have our brain that suffers a traumatic injury. Brain swelling or bleeding starts to increase our intracranial volume, right? So remember that idea that the skull is a very enclosed, tight space. When we have an injury to that area, we have edema and swelling, maybe even bleeding. So now, whatever tissue is in the brain, our nice cerebrum, brainstem, cerebellum, all of that bleeding and bruising and swelling, now something's got to give. Part of that brain tissue needs to expand into a different area, and it may need to even herniate out of the skull. So that's dangerous. So our rigid cranium allows no room for this expansion, so the intracranial pressure continues to increase. The pressure on our blood vessels within our brain causes blood flow in the brain to slow down. So if we slow blood flow to the brain, we are losing oxygen, we're losing nutrients that need to get to our neurons. That's where hypoxia and ischemia come from, as well as hypercapnia, right? The buildup of acids in the brain that can't escape because our blood supply, our arteries and veins aren't able to work correctly. This is indeed a vicious cycle, and it's not going to stop unless we correct the cause, which is to decompress that skull and get that cerebral edema under control so that we can have oxygenated blood get back up to the brain. Okay. So that is all part of that secondary injury that occurs. So let's talk about our forces. What forces can cause a traumatic brain injury? Concussion. This is usually classified as a mild traumatic brain injury. Usually involves a brief alteration in mental status that results from some type of trauma, like banging your head against someone else, or maybe heading a soccer ball too hard, or colliding with someone in a football game. This can cause secondary injury that results in headache, nausea, vomiting, sensitivity to light, maybe even a little bit of amnesia. But usually it resolves within a couple of days to a week. Keep in mind that anytime a patient has any type of brain injury or head collision or falls and hits their head, they should be monitored at least every 2 hours. They should have a neurocheck performed. You've probably hit your head and your parents kept waking you up every couple of hours, making sure you were okay. And that's why we want to know the extent of that secondary injury. You've probably heard of contusion in the past. Cerebral contusion is a little bit more severe than a concussion, and this involves actual bruising of the brain tissue with a possible hemorrhage on the surface of the brain, an intracerebral hemorrhage, or even a subarachnoid hemorrhage. And of course, the signs and symptoms are going to develop based on the size of that contusion and how much swelling occurs and how much bleeding occurs. The patient with a cerebral contusion may lose consciousness for a short amount of time. Usually our blood pressure and temperature become abnormal depending on what's going on. Patients may recover consciousness quickly, then they usually go into what's called cerebral irritability. And this occurs when the patient's conscious, but they're easily startled by any stimuli that could be occurring, like noises, light, voices. And then we move into diffuse axonal injuries. And these occur when you have a patient who has widespread damage to both cerebral hemispheres, including their corpus callosum and their brain stem. This can be seen with mild, moderate, or severe head trauma, and this is also referred to as a shearing injury or a shearing of axons, as well as straining. So this can be extremely dangerous. The patient's going to experience an immediate coma, global cerebral edema, so there's swelling everywhere in the brain. And the hallmark sign of this is posturing, different posturing, particularly decorticate posturing and decerebrate posturing. So decorticate posturing involves this abnormal flexion of our upper extremities and extension of our lower extremities. And this is indicative of damage to the upper portion of our midbrain. Decerebrate posturing involves extreme extension of the upper and lower extremities. Decerebrate posturing is severe damage to the brain at the lower midbrain and upper pons. Remember that decerebrate is typically much more severe than that of decorticate, though they are both terrible. And so diagnosing diffuse axonal injury usually is a result of clinical signs in conjunction with a CT or MRI scan. And of course, recovery depends on the severity of the injury. We can also have subarachnoid hemorrhages that occur, or intracerebral hemorrhages, which are actually within the brain tissue. So when you think intracranial, think anything that can occur within the brain or those layers of the meninges. And then when you think intracerebral, think the actual brain tissue and bleeding that's occurring within that white matter and the gray matter. So after a head injury, depending on what happens, whether or not it is blunt force trauma to the skull, or the patient has a fall, or maybe they're in a car accident and their brains kind of just rattled all over the place within the skull, we can have bleeding that occurs in any of these areas. And depending on the quantity of blood loss, depending on the amount of swelling that occurs to the brain tissue along with the amount of bleeding, that's going to determine what kind of signs and symptoms we are going to see. Typically with a bleed, your patient is going to complain of the worst headache in their life. They may also have an altered level of consciousness or even a loss of consciousness, or just maybe a decreased level of consciousness, so they might be really lethargic. They may be slow to respond to you, have difficulty opening their eyes and sensitivity to light. Usually our epidural hematomas or intracerebral hemorrhages are extreme emergencies. Your patient's more likely to bleed quickly in these areas, and your patient will undergo what's called a burr hole procedure to decrease the intracranial pressure emergently and drain out that excess blood, decompress the skull, and allow for expansion. Remember, that skull is usually very tight and hard. It doesn't want to expand. So what we'll do is manually expand that space for the brain. Our subdural hematoma is typically considered less severe. Now again, the degree of bleeding will determine how severe the neurological injury is, but subdural hematomas usually are able to clot off rather quickly. There's more space for bleeding in that space, in that subdural space, than there is in the intracerebral space, which makes sense. And the subdural hematomas are very common, especially in the elderly who fall and hit their heads. Think about your elderly patient that's on an anticoagulant for AFib, or maybe they had a prior MI or a stroke and now they have to take an anticoagulant. They're at very high risk. So now we're going to move on into our fractures. So we talked about what happens at the brain tissue level when we have traumatic injury. We can have bruising, contusions, concussions that harm the actual brain tissue, or we can have bleeding, of course, as a result of harming the blood vessels. But what happens when we have a fracture of the skull? We can have what's called a depressed skull fracture or basilar skull fracture. When we have a depressed skull fracture, this occurs when part of those bone fragments become depressed and then embedded into brain tissue, which can, of course, harm that brain tissue and cause that localized swelling and then that secondary injury that results. It's important to keep in mind with a basilar skull fracture, you may have a cerebrospinal fluid leak. And the way that we detect this is by putting some type of tissue to that area if we see leakage of a clear fluid. And what we will see is a halo sign, which is blood stain that's surrounded by like a yellowish stain, and that is indicative of a CSF leak usually. Of course, we can confirm that through further testing, but that's just like a bedside assessment that you can do. So drainage of CSF can be a severe problem because it can predispose your patient to infection and develop something like meningitis, or even an abscess or osteomyelitis can occur if organisms gain access to those areas. So your patient with a suspected skull fracture, of course, is going to undergo a CT, an X-ray, and then followed up, of course, with an MRI, so that we can get a really good look at the anatomic nature of our injury. Our non-depressed skull fractures don't require surgical management, but if for whatever reason we have skull fragments that are embedded in the brain, we may have to go in and surgically remove them. Not us, the neurosurgeon. Of course, if you suspect a CSF leak from that basilar skull fracture, or if any type of head trauma, if at any time you see clear drainage from the nose or the ears, you need to notify your provider right away. It's important to remember that your patient with skull fracture or fractures to their nose should not have a nasogastric tube or a nasopharyngeal airway inserted, because there's risk of further damaging those bones. We need to establish an oral airway if at all possible, or like an orogastric, an OG tube, or even some type of peripheral nutrition. So we classify our TBIs as mild, moderate, or severe. Again, mild injuries are usually a brief loss of consciousness, maybe even a short amount of amnesia. The patient may experience transient neurodeficits, usually have good recovery, good outcomes. But if they have repeated injuries, their outcomes are, of course, poorer. You know, if they're constantly playing football and have those collision, head-on injuries, and they're, constantly getting headaches, the long-term effects are going to be pretty detrimental. And then our moderate injuries are usually these frequently occurring blast injuries, acceleration, deceleration injuries. So think about someone who maybe races cars, or they are in the military and they're doing a lot of combat training and things like that. They're prone to blast injuries, acceleration, deceleration injuries. The same thing is just as common in football players and people who do contact sports like rugby, football, soccer, anything that could cause constant repeated trauma over a long period of time. This type of injury can result in a loss of consciousness that extends from 30 minutes to less than 24 hours. And the time that the patient can have amnesia becomes, extended. Their Glasgow Coma Scale is usually anywhere from 9 to 12 in the immediate period after injury. And this patient may suffer long-term effect PTSD as well as other neurological and neuropsychiatric disorders. When you have someone with a severe TBI, you have a very harmful traumatic event that occurs, some type of blast injury, penetration injuries, acceleration, deceleration injury. This patient usually is that patient that suffers the immediate coma. They have a loss of consciousness, of course, greater than 24 hours. They are in the ICU. Their GCS is less than 9. They're probably intubated. They have multiple organ trauma from whatever injury they've sustained. This type of injury results in death, severe neurological and neuropsychiatric deficits. So what does your patient with a traumatic brain injury look like? What are they going to present with? We talked about before when we have excessive swelling in one compartment of the brain and we have hypoxia in the brain, and then we have all of the toxic metabolites that build up in the brain because of a lack of oxygen. We have that altered level of consciousness, decreased level of consciousness, even loss of consciousness. Your patient with a mild traumatic brain injury, mild to moderate, may present with confusion. So they may be alert, just, very confused, kind of out of it. Their pupils may also change in size, shape, and their ability to respond and accommodate to life. So your pupillary assessment is extremely important with these patients. Sudden onset of neurodeficits. Anytime your patient has a change in level of consciousness, no matter what type of patient you're caring for, it could be a respiratory patient, could be a cardiac patient, you always need to be attuned to a change in level of consciousness. We can also have changes in our vital signs. Your patient may have a change in their breathing pattern, depending on whether or not the respiratory center in their brain is affected. They may also have bradycardia or tachycardia, or even difficulty in regulating their temperature. They may be hypo or hyperthermic, depending on where the injury has occurred. If it's occurred to the parietal or occipital region, they may have difficulties in sight or a hearing impairment if their temporal lobe is damaged. Sensory dysfunction if the sensory cortex is affected. And then again, that terrible pounding, nonstop, most severe headache I've ever had in my life is definitely a warning sign that your patient could either have some type of cerebral edema and swelling or a brain bleed. So a very late sign, a very severe sign of a traumatic brain injury would be seizures. So we can have seizures for a multitude of reasons, but typically when you think of traumatic brain injury, remember the 4 H's, particularly hypoxia and hypercapnia. That results in a decreased amount of vital nutrients, particularly glucose, to the brain. If we don't have oxygenated blood flow getting to the brain, we don't have glucose. And remember from your first semester where you talked about electrolyte abnormalities, and we know that the brain needs an adequate amount of glucose to keep functioning, right? That's what we run on for energy. So if our glucose levels tank because we have no oxygenated blood flow to the brain, we will start seizing. And again, in order to correct this, we have to get down to the root of what's causing that hypoxia, which is usually the cerebral edema, which requires, or the bleeding that requires surgical decompression. So our diagnostic tests, we will take them for a CT scan. Usually a stat head CT is done on arrival. We can also do x-rays, and that will evaluate for any type of fractures in our skull. We can then follow up with an MRI, which typically takes a little bit longer to perform than a CT. And that will give us more detail about that brain and what parts of the brain are damaged. If there has been decreased blood flow to a certain area of the brain, the MRI will show us if there's been an infarction. This patient will go to the ICU they will be admitted to a neurocritical care unit or a surgical ICU where they can do that decompression surgery and alleviate that cerebral edema or bleeding that's occurring. When we do our labs, we are going to look at a lot of different things. If the patient is seizing and maybe they're on anti-epileptic drugs at home, we're going to draw some serum levels. We're going to make sure that this seizure is not a result of being subtherapeutic with their Keppra or their Dilantin. We are also going to grab some ABGs. We're going to look at the level of hypoxia, hypercapnia. We're going to draw a CBC and a BMP like we always do. And then we will probably do our coagulation studies as well, especially for the patient who's experiencing a bleed, because we may need to administer an agent to reverse the effects of a medication like Coumadin or warfarin that's causing the blood to be too thin. We'll also undergo a toxicology screen, whether it's serum levels or a urine tox, to determine whether or not they're under the influence of any substances that could be exacerbating the altered level of consciousness. So now a little bit about our nursing assessment. So we briefly mentioned the different types of things that you might see, the different clinical manifestations, but remember, you still need to do your entire head to toe assessment, right? Think about your level of consciousness, your GCS, pupils, cranial nerves, motor and sensory function, reflexes, posturing, and vital signs. You're going to be doing this if you're in an ICU, sometimes every 15 minutes, you're going to be assessing for changes. If you're on a med surg floor, like where I work, you're going to be doing it every 2 to 4 hours, depending on what the patient has going on. Cushing's triad are 3 signs of increased intracranial pressure. This would be an increase in our systolic blood pressure, a decrease in our pulse, and a decrease in our respiratory rate. Okay, so keep in mind that increased ICP is associated with these 3 signs. Again, pay attention to your posturing, your decorticate versus your decerebrate, and what parts of the brain are being affected when you see that posturing, like we mentioned before. So your nursing management of your patient that comes in with a TBI, if you're in an emergency department, need to first stabilize and immobilize that cervical spine. Because when I have a patient with some type of brain trauma, I am always assuming that they have a cervical spine fracture, the worst thing that you can have, before I treat them, right? And that's going to trigger the assessment, right? Your airway, breathing, circulation, okay? Because if they have a cervical spine injury, chances are they can't control their airway, they can't breathe spontaneously, and they may or may not have adequate circulation, adequate perfusion, both to their brain and the rest of their body. So immobilize that C-spine, okay, initially. Establish an airway, okay, get a patent airway. The patient will probably need to be intubated, okay? Breathing. We want our O2 sats as optimal as possible. Why? Because the brain is losing oxygenated blood flow, okay? So we need to optimize the amount of oxygen we have and avoid hypercapnia, okay? We need to make sure that we are ventilating them appropriately and allowing for the excretion of CO2. And then circulation. We want to avoid systemic hypotension while at the same time avoiding increased intracranial pressure, okay? And we do this through fluid volume resuscitation, okay, that keeps our intravascular space nice and full, okay? We need enough fluid in our bloodstream, but at the same time, we don't need increased pressure in our brain. Okay, so now we've stabilized our patient, we've stabilized our cervical spine, we have a patent airway, patient's breathing either spontaneously or we're mechanically ventilating them, and we have adequate circulation, we have adequate circulating intravascular volume. We'll either take this patient for a head CT if we suspect that they have a bleed. We'll definitely do a CT, X-ray, MRI of their cervical spine to assess for cord compression, fractures, any type of neurological deficit, and then we will transport them from the X-ray, from the CT, from the MRI to the critical care unit, where they will further be stabilized. We are going to position their head to facilitate venous drainage. So we usually will keep the head of the bed elevated at least 30 degrees. We want to maintain normothermia. We need to make sure that they are adequately sedated if they're intubated. We need to make sure that we maintain a very calm and therapeutic environment that allows their brain to truly heal. I know it's hard in critical care environments where we have lots of beeping noises and machines and alarms and whatnot, but it's very important that we allow the brain to rest and really reduce stimuli for this patient. Because the more we arouse them, the more we agitate them, the more intracranial pressure is going to increase. They're going to have hypertension. They're going to be irritable. We are also going to want to, again, avoid hypoglycemia, because hypoglycemic states, especially within the brain, can induce seizures. And our brain needs energy, our brain needs glucose, so we need to optimize the absorption of glucose by our brain cells. This patient is also going to be maintained on what's called seizure precautions. So you need to take measures to prevent, in the event of a seizure, you need to have certain safety measures in place. So when I implement seizure precautions for my patient that's had a stroke, or maybe they have a brain tumor or a traumatic brain injury of some sort, I am making sure that my environment is safe, my room is safe. I have oxygen set up, I have suction set up. Luckily, if the patient's already mechanically ventilated, you have oxygen support there, but you may need just an extra wall set up for oxygen, as well as a suction source. You want to pad your side rails. So certain facilities will have pads that you can strap onto the side rails, or you can take blankets and wrap your side rails tightly, because your side rails are usually very hard. And in the event that the patient did start seizing, you would want to protect that patient, protect their limbs and their head, especially if they already have a brain injury. You're going to want to make sure that the bed is lowered and locked. So not necessarily the patient being flat, they still need to be at least 30 degrees to facilitate that venous drainage from the brain. But at the same time, the bed needs to be in a low position and locked, because if in the event that the patient did fall out of the bed, we want to be as close to the ground as possible. So again, with your traumatic brain injuries, assume that your patient has a cervical spine injury until that is ruled out via CT, MRI. You're going to want to stabilize them with a cervical collar of some sort, use a spinal backboard, or other immobilization device, depending on what your hospital has. We need to, again, break that cycle of the 4 H's, that hypoxia, hypercapnia, hypotension, which is systemic, and then hypertension, which is intracranial. So in order to avoid or prevent further hypoxia, we want to maximize the amount of oxygen that we get to the brain, right? And we want to decrease the amount of CO2 and other acids that are building up in the brain. And the way we do that is usually through mechanical ventilation and ABG monitoring to make sure that we are at those therapeutic levels, optimal oxygen and optimal CO2 levels. Then we may need an arterial line, an ART line, that gets inserted into a radial artery and detects in real time blood pressure measurements. We want to avoid hypotension and keep our mean arterial pressure, our MAP, above 65 millimeters mercury. We use different medications, different IV fluids to maintain that intravascular fluid volume and avoid hypotension. And we may use particular diuretics, medications, as well as surgical decompression to avoid intracranial hypertension, or increased intracranial pressure. So those are the 4 H's. We are also going to pay attention to our electrolyte balances. Remember, when we vigorously fluid resuscitate somebody, we may be at risk for electrolyte imbalances. Your patient, if they do not have a skull fracture, or like a nasal fracture, or some type of basilar skull fracture, we may insert an NG tube to decompress the stomach, reduce gastric motility, and prevent them from aspirating. But again, this is contraindicated. At least an NG tube is contraindicated when your patient has a skull fracture, or when they are suspected to have a skull fracture. We want to manage pain and anxiety. So again, this patient will most likely be sedated, especially if they're mechanically ventilated. And then they may be getting pain medications around the clock to kind of help with the, exploding headache that they might have. Again, seizure precautions and surgical decompression with neurosurgery if indicated. So when we monitor ICP, I mentioned something about inserting a drain, what's called an EVD, an extraventricular drain, which I have a picture of here. So remember, that skull is a closed, tight space, right? Because we have those 3 elements, the brain tissue, blood, and cerebrospinal fluid, CSF, if we have an elevation or an increase in one of those parts, swelling in one of those parts, we will have increased intracranial pressure. If for whatever reason the intracranial pressure were to continue to increase and that pressure is not relieved, in other words, we don't decompress the skull or insert a drain to, relieve it of the excess bleeding or swelling or cerebrospinal fluid, something has to give. Some part of that brain is going to have to herniate, is going to have to shift into a different area, particularly down into the neck, which is extremely dangerous. So what we will do is we will either take this patient to surgery and take part of the skull off and decompress that area. If it's a bleed, we will decompress the bleed, we'll remove that blood. Or we can insert a drain, an extraventricular device, into one of the ventricles of our brain, and that will keep intracranial pressure under control. We'll calibrate it to a certain level to where excess CSF is able to drain into that external device. And we will make sure that our ICP maintains between 5 and 15 millimeters of mercury. Anything greater than 20 requires intervention. Okay, we need to relieve that increased intracranial pressure. Be attuned to those signs of increasing ICP that we mentioned before, predominantly a change in your level of consciousness, along with a headache, weakness, pupillary changes. That's why your continued assessment is so important, your ongoing assessment of your patient, as well as Cushing's triad, which we mentioned before, was that increased blood pressure, decreased pulse, and decreased respiration. It's a very ominous sign. So in order to further treat increased intracranial pressure, we are going to administer certain medications to decrease cerebral edema. In other words, we are going to pull extra fluid out of the brain and pull that fluid back into the intravascular space to reduce the amount of swelling occurring in our brain cells. We use osmotic diuretics like mannitol to do this. Keep in mind that mannitol works very quickly. We can use hypertonic saline to do this. We can also use sedation to decrease our ICP. We will administer Tylenol or other antipyretics to control fever. And again, maintain our blood pressure and optimal oxygenation. So a MAP greater than 65, a cerebral perfusion pressure greater than 60. We want our CO2 low normal, and we want our oxygen to be greater than 95%, our O2 sats to be greater than 95%. We're going to prevent seizures by using anti-epileptics, like a loading dose of Keppra or phenytoin, Dilantin. We also want to make sure we are providing adequate skin care, preventing skin breakdown, especially if your patient is intubated, sedated, they can't move on their own. We need to do a really good job of turning them, cleaning them, repositioning them in a way that doesn't cause them to become irritable and over aroused to the point where we're increasing intracranial pressure, but at the same time we're preventing skin breakdown and pressure injuries. Sometimes, depending on how unstable your patient is, as far as their blood pressure, intracranial pressure go, you may not be able to move them at all. We also want to promote optimal nutrition. And again, we can do this through an NG tube if not contraindicated, or an OG tube. We may need to provide peripheral nutrition, so TPN or PPN. And of course, we want to preserve our bowel and bladder function, so getting them on a bowel regimen of some sort, making sure that we are mobilizing them as soon as possible if they have a surgical procedure, so if they have surgical decompression. Once it's appropriate, we want them to get up out of bed, be working with physical and occupational therapy. Of course, in a critical care setting, this is not going to happen right away. We need to make sure that all of their numbers are stable, but that's going to help preserve our bowel and bladder function. Our complications of TBI, so there are many long-term complications, but in the short term, again, remember we want to optimize thermodynamics and temperature regulation. So if your patient has uncontrolled hyperthermia, that's a problem. They may need a cooling blanket or a cooler temperature in the room, or maybe even ice packs. We can also have imbalances in sodium. Depending on what part of the brain is affected, we can have pathologic diabetes insipidus, as well as syndrome of inappropriate antidiuretic hormone. If the pituitary gland is affected, we can also have cardiovascular complications. Remember, we said that hypotension is very common. Systemic hypotension is very common, as well as bradycardia. So we need to prevent these through adequate fluid resuscitation. And then, of course, we need to really pay attention to our family for this patient that's in the critical care setting. This is, of course, traumatic brain injuries are exactly what they sound like. They're traumatic. So if you have a patient who's admitted to the ICU, it's really important you as the nurse are tending to the family and their needs, as well as the patient, and being that calming support system for both patient and family. So our nursing interventions, what your vital signs and your neuro checks are always your priority, right? Your ABCs. It's also important to be able to communicate with this patient, which may not always be easy depending on the level and severity of neurologic injury. When the patient is able to finally tolerate physical activity and by mouth or PO intake, we can get that speech therapist in there. We can get physical therapy and occupational therapy at the bedside to help this patient regain some level of function. Think about your patient that is posturing. So if they have decorticate or decerebrate posturing, how we're going to try to prevent contractures, right? There are different devices that we can use to prevent the limbs and extremely contracted and stuck that way. So we really need to pay attention to positioning, as well as comfort. So a question before we move into our next section, which is spinal cord injury. So the nurse assesses the level of consciousness of a patient who suffered a head injury and determines that the patient's GCS score is 15. Which of the following responses did the nurse assess to determine the GCS score? So if you're familiar with the GCS scale, you know that the three elements that we are assessing are our eye-opening response, our best verbal response, and our best motor response. So if you chose A, C, and E, you are correct. And moving right along into our next section, we're going to be talking about spinal cord injuries. So spinal cord injuries, like traumatic brain injuries, are usually caused by some type of blunt trauma, whether it's a flexion injury. We can also have hyperextension, the head and the neck hyperextend back. Also have penetrating trauma, which, if someone is stabbed somewhere or someone is shot through their spinal cord, that can cause a penetrating traumatic injury. It's important to keep in mind, like we said before, that we have 31 pairs of spinal nerves that come out from the spinal cord. And those include ascending and descending tracts that carry both motor and sensory stimuli. Depending on the level of injury, where that spinal cord injury occurs along the spinal cord is going to tell you, or at least give you an idea of what to expect as far as what the patient might be experiencing with, their motor or sensory deficits. They may have a motor deficit, they may have a sensory deficit, they may have a mixture of both, depending on where the lesion or damage is in the spinal cord. We also have complete or incomplete injuries. So incomplete is usually a partial compression to the spinal cord, whereas complete usually involves the entire transection of the cord. It can be that the cord is severed. It could be that the cord is completely compressed. Either of those cases would constitute a complete injury, and the patient usually has complete motor and sensory loss in that case. So again, these are just some images of what types of injuries that you can have. So just like with traumatic brain injuries, we can have primary spinal cord injuries, and then we can have a secondary injury that occurs as a result of the primary injury. So a primary spinal cord injury is where we have traumatic mechanical injury that causes small hemorrhages in our gray matter. That leads to edema in the white matter, and then necrosis of that surrounding tissue. This is usually a result of the initial insult, initial trauma that occurs. Then the secondary spinal cord injury is the result of this primary injury, where the nerve fibers surrounding that area, so remember we have the spinal nerves that come out from the spinal cord, these start to swell up and then disintegrate. This is usually caused by hypoxia, so decreased blood flow to those nerves, decreased perfusion, hypo or hyperthermic states, hypotension, and then electrolyte imbalances. So the area of cells, so the nerve cells that are close to the primary injury, those nerve cells that come off the spinal cord are damaged. They're very highly susceptible to death. This secondary chain of events produces ischemia, hypoxia, and edema, and maybe even hemorrhage, depending on how severe the edema is and how compressed those nerves and blood vessels are. And then we in turn have destruction of the axons and the myelin that surrounds those nerves. So basically the spinal nerves just disintegrate as a result of the severity of the spinal cord injury. This, with the appropriate medications, the appropriate treatment, is thought to be reversible within the first 6 hours of our primary injury. So we have to act quickly for the patient who has a spinal cord injury to prevent this secondary injury from occurring. There are a multitude of cord syndromes that we can experience depending on what type of injury is occurring. So if you have a central cord syndrome, you might lose motor power and sensation, the anterior side of your body. This is an incomplete loss because everything else is intact. Anterior cord syndrome is the most common. This is where we lose motor power, pain and temperature sensation, but we usually have our position, vibration, and ability to sense touch. Those are preserved. We can have lateral cord syndrome, which is known as Brown-Séquard syndrome, and this is where we have contralateral loss of pain and temperature sensation. And then we have loss of voluntary motor control on the same side as cord damage. So that's really interesting how that occurs. So as you can see, depending on the area of cord damage or cord compression, we're going to see different types of sensory and motor loss. Cauda-Equina syndrome. This is usually caused by severe spinal cord compression of the nerve roots of the lumbar spine, usually between L1 and L5. In the saddle area, pain, incontinence, numbness, Tingling, this is an emergency. Cord compression is an emergency. The treatment for this includes surgical decompression. So referring back to our complete versus incomplete spinal cord injury, we often refer to the ASIA or Asia Impairment Scale, where A ranges from complete spinal cord injury where no motor or sensory function is preserved, to E, which is normal. Motor and sensory function are normal. So pay attention to the different levels of injury and how they're classified. This is using the sacral segments of S4 to S5 as an example. The patient with spinal cord compression that we see on MRI is a traumatic injury that is completely compressing that spinal cord, and it's an acute emergency that will require IV steroids like Decadron or dexamethasone to reduce that edema and swelling and consequent secondary injury, and then surgical decompression if the patient is a surgical candidate to prevent permanent damage, permanent loss of sensory and motor function. So our clinical manifestations of spinal cord injury. The level of spinal cord injury is going to determine the severity and the signs and symptoms of what your patient is going to present with. So for instance, in the cervical spine, if we have a cervical spinal cord injury, the patient may or may not be able to initiate their own breaths. They may or may not be able to breathe spontaneously. So we most likely need to intubate them. Moving down into the lower portion of the cervical spine, into the thoracic spine, this patient may be able to breathe on their own, but may need some type of respiratory support, depending on the severity of the injury, if it's complete versus incomplete. Below T12, there's usually no interference with respiration. Keep in mind that your patient, no matter where their injury is, they can have ascending edema. So in other words, swelling and secondary injury can occur above the level of injury. So if you have a T6 injury, edema and swelling can occur above that T6 injury and can cause respiratory compromise, right? It can affect the nerves that are responsible for respiration. We also need to pay attention to circulation. ABCs go everywhere with us. Your patient may present with hypotension, systemic hypotension, and bradycardia. And we want to avoid a blood pressure, a systolic blood pressure less than 90. We need our MAP to not only be greater than 65, but optimally between 85 and 90. This patient may need vasopressors, vasoactive medications to keep their blood pressure and their heart rate up. Reflexes. Your patient with a spinal cord injury may or may not have control over their reflexes. They may have spasticity or hyperactive deep tendon reflexes. You're probably familiar with dermatomes. Okay, so it's important to know what level of injury corresponds with what types of movements. If you have an injury at C1, your patient will most likely not be able to move, feel, or breathe on their own. T12 and below, little respiratory compromise is expected there, but depending on the severity of the injury, your patient with a T12 and below injury may not be able to walk. So how do we manage an acute spinal cord injury? Just like the traumatic brain injury, we want to pay attention to our ABCs, airway, breathing, circulation. Immobilize that spine, immobilize the spinal cord, and fluid volume resuscitate them. They may need to be mechanically ventilated. They may need to be on vasopressors to manage their blood pressure. We'll talk a little bit more about neurogenic shock and what to look for there. These patients will be on high-dose steroids, the vasopressors, pain medications, a bowel regimen. They may not, depending on where the level of injury is, they may not be able to feel the sensation to defecate or feel the sensation to urinate. Your patient that has hyperactive deep tendon reflexes, rigidity, spasticity, may need to be on a muscle relaxer. We like to use baclofen a lot, especially for spasticity. We said before that we have to stabilize them. Okay, if they have a fracture or spinal cord compression, they may need to go for surgery. but we will use traction. We will use different types of body braces, back braces, neck braces to help the patient move in bed. These are the different types of surgical interventions that we can do. A laminectomy, we can repair, we can fuse the spine. We may need to go in and evacuate a hematoma if there's excessive bleeding that's causing cord compression. We can realign the spine with nails, rods, screws. The goal of all of these interventions is to stabilize that spine and protect that spinal cord. Again, our nursing interventions, just like with the traumatic brain injury, are going to be those vital signs and neurochecks, our ABCs. We want to prevent complications, which we'll talk about. And we want to prevent contractures and wounds. So our complications of spinal cord injury. We have spinal shock, neurogenic shock, autonomic dysreflexia, and then, like we said before, respiratory compromise. Spinal shock is usually expected after that primary injury. This is a sudden depression of reflexive activity that occurs below the level of our spinal injury. So if we have a T6 injury, we are going to have depressed reflexes, difficulty with motor ability, flaccidity, a lack of sensation below that level of injury. And this happens very quickly after our spinal cord injury. The days following that spinal cord injury, after the secondary injury has had a chance to take effect, we can have what's called neurogenic shock. Okay, so this is similar to your other forms of shock. This is caused by the loss of function or regulation of the autonomic nervous system. What's the autonomic nervous system? We talked about it earlier. That's our sympathetic and our parasympathetic, right? So our sympathetic is our fight or flight, and our parasympathetic is our rest and digest. Those in spinal cord injuries, those two systems don't work very well together. So what happens here in neurogenic shock is that we have a sudden drop in blood pressure, okay, due to decreased cardiac output. In response to that decreased blood pressure, right, a compensatory mechanism, our heart rate will try to increase. We'll try to increase our heart rate because we want sufficient cardiac output. That being said, our sympathetic branch of our autonomic nervous system cannot keep up. And the result is widespread vasodilation. That widespread vasodilation, like other forms of shock, decrease the amount of cardiac output that we have, right? Decreases the amount of intravascular fluid volume that we have, and thus decreases perfusion. Okay, so we have decreased circulating oxygenated blood. This is an emergency, just like every other form of shock. Spinal shock, usually expected after spinal cord injury. So autonomic dysreflexia occurs as a result of a sustained stimulus below T6, at T6 or below. Okay, so the patient has an injury at T6 or above, and the stimulus is occurring at T6 or below. Okay, that stimulus can include pressure on a certain area. Maybe the patient is laying on one side for too long, it's compressing a nerve. The patient can have a full bladder, maybe even a kinked urinary catheter can cause urinary retention and bladder distension. Fecal impaction, constipation can cause this, or tight clothing. So if the patient has pants on with a tight belt, this could also cause some sort of stimulus at T6 or below. So that stimulus gets sent to the spinal cord, right? And it travels up the spinal cord. Because remember, all of the sensory and motor input that we have, all of the impulses that we have and the things that we touch and feel and our pain and pressure sensations, they all travel from our peripheral spinal nerves to the spinal cord and travel up our spinal cord to our brain. Well, if you have an injury, T6 or higher, remember, if you have an injury here, that stimulus is going to cause, at the level of injury, the release of sympathetic chemicals, sympathetic nervous system chemicals like epi and norepi. Okay, so we have the release of epi and norepi that occur as a result of this stimulus. What epi and norepi do is stimulate that sympathetic nervous system response, right? The vasoconstriction, the increased blood pressure, increased heart rate, right? So what happens is that as that stimulus travels up and those chemicals are released, the sensors in the brain, in the heart and in the brain, the baroreceptors, pressure receptors, they sense this increase in blood pressure. They sense the vasoconstriction. They sense the increased need for increased cardiac output and vasoconstriction. So what happens is once those chemicals get to the brain has a response. It's a parasympathetic response to that stimulus. So what happens is those chemicals come to the brain, and the brain says, okay, no, we're gonna stop this blood pressure from rising. So what the brain does is it stimulates the parasympathetic nervous system through the vagus nerve with the hope of decreasing blood pressure, decreasing heart rate, and causing vasodilation. However, remember there's a spinal cord injury at T6 or higher. So as that stimulus through the vagus nerve comes down from the brain through the vagus nerve, it gets stopped at the level of injury. So that parasympathetic response gets stopped at the level of injury. Okay? So when that happens, at the level of injury and higher, we have a parasympathetic response. We have vasodilation, facial flushing, okay? Because the rest and digest response is trying to get down to that bladder or to the impacted colon, or down to that area where, you know, we have to change positions because we're on that pressure point for too long. But it gets stopped at the level of injury. So because it gets stopped, the parasympathetic response gets stopped, we expect the blood vessels above the level of injury to start to dilate, because that's a parasympathetic response. Those blood vessels dilate. However, below the level of injury, where the stimulus is at T6 or below, we are still having vasoconstriction as a result of the sympathetic response. Okay, so the parasympathetic can't get down past the level of injury. The sympathetic keeps coming up. Okay, it's this constant vicious cycle to where the sympathetic nervous system is triggered so much and we're releasing so many sympathetic chemicals that the blood pressure keeps rising. Our blood pressure just keeps rising and rising and rising. So in the patients that I've encountered that have autonomic dysreflexia, they present with blood pressures in the 200s and they have a terrible headache. They look very flushed in the face. They're hot, they're sweaty above the level of injury. And then below, at T6 or below, they are experiencing vasoconstriction, maybe even like goosebumps. They're typically much cooler, right? Because that sympathetic nervous system causes vasoconstriction. Okay, but above the level of injury, we have the parasympathetic vagus nerve response coming down, trying to dilate everything and relieve that stimulus, but it's not making it down to the area that's being affected, which could be the bladder or it could be the bowel or a pressure point of some sort. So then how do we fix this? Well, we have to fix whatever stimulus is causing the sympathetic response. If it's a kinked urinary catheter, we have to unkink the catheter. If it is a full bladder and the patient doesn't have a catheter, we may need to straight cath them. That being said, your patient may be on routine bladder scans and routine urinary catheterization, intermittent straight catheterization, to prevent this from happening, because they may have already lost that sensation and motor ability to either evacuate their bladder or evacuate their bowel. So we may need to do it for them. We will probably need to put them on a bowel regimen as well. Or we may just need to change their position or loosen tight clothing. So a simple fix for a medical emergency. If this is left untreated, your patient will be in a hypertensive crisis and could have a stroke as a result of the hypertensive urgency, either an intracranial bleed of some sort. You do not want to leave your patient if for whatever reason you suspect autonomic dysreflexia, you should be taking blood pressures every 5 to 15 minutes, depending on how high the blood pressure is. Of course, you want to treat the cause first, as opposed to just medicating the high blood pressure. If you do treat the cause, say, I catheterized my patient and his blood pressure is still in the 170s, 180s systolic, I may need to call my provider and get something additional for blood pressure. But that, again, is going to be up to the provider. Your job is to prevent this complication, frequent repositioning, making sure that you are properly toileting your patient, whether that means an intermittent straight cath or putting them on a bowel regimen, and notifying your provider if you do suspect autonomic dysreflexia, because your patient's not going to be able to feel it. They're just going to be super flushed in the face, a terrible headache, maybe even nauseous and vomiting, depending on how high their ICP is. So we see where the difference is between neurogenic shock and autonomic dysreflexia. So how are we going to collaborate for our patients with spinal cord injuries with the interdisciplinary healthcare team? This is a joint effort between you, the provider, the neurosurgeon, or the neurologist, as well as PT, OT, and maybe even speech therapy. We need to make sure that we are preventing complications like neurogenic shock, autonomic dysreflexia, respiratory compromise or respiratory failure, as well as managing the complications of those conditions. Your patient may need a long-term care placement, maybe even after they go to rehab for a couple of weeks to months, they may need to transition to long-term care. And that's a discussion that needs to be had with both case management and social work, as well as family. Some patients have the ability to return home and be cared for by family members or other members of the community who can come in and provide care. Home health nurses, home physical therapists, and occupational therapists are great. You also want to assess the ability of the family to cope, because this can be really hard for someone who was previously completely independent and now they've been involved in a car accident or some other traumatic event and their life is completely changed. Ultimately, the goal here with teaching all of this is to preserve their independence and their quality of life. Again, some patients may need a long-term care placement, but others may manage very well on their own. As long as they have the correct assistive devices and the appropriate care at home, they can function pretty well. I've had patients who were very successful in life. I met a computer engineer who he was wheelchair bound and he could not move his legs and he could not feel when he had to urinate or defecate, but he was able to tell me when he started to feel like his blood pressure was increasing, because he would get a little flushed, and he was actually one of my patients that did come in with autonomic dysreflexia, and he also had a pretty severe sacral wound. Luckily, he couldn't feel the sacral wound, and it looked very painful, but given that it was a very deep decubitus ulcer that resulted from him sitting in his wheelchair for prolonged periods of time, we had to care for that while at the same time managing the autonomic dysreflexia, while at the same time he was on his computer doing his computer engineering work. So it's very interesting, just the dynamic and how patients can cope and manage to live with their disease and what's happened to them after, especially after spinal cord injury. It's quite amazing. So we talked about some nursing interventions, and we also have our nursing diagnoses. There are many of them that you could come up with for patients with traumatic brain injuries and spinal cord injuries. And let's do a little knowledge talk question. So, which interventions should the nurse's plan of care include to help prevent autonomic dysreflexia in a patient with spinal cord injury? Select all that apply. If you selected A, C, and D, you would be correct. Again, we want to prevent any type of fecal impaction or urinary retention that could cause that stimulus, as well as promoting frequent positioning. that will prevent your patient from sitting on one, spot for too long. Moving on to our last concept for this PowerPoint, we are going to talk about brain tumors. So remember your cranial nerves, we mentioned them earlier. Your cranial nerves are going to be very, very sensitive to the presence of a brain tumor. Whereas your spinal nerves and your motor and sensory control that stems from your spine are very sensitive in a spinal cord injury. When you have a brain tumor somewhere in the brain, that area, that lobe of the brain is going to be affected. Primary brain tumors are usually lesions that begin in your brain and stay within the skull. They occupy the space within the skull. We can normally see them on CTs or MRIs. The tumor is normally an abnormal growth of cells. There are many, many types of tumors that your patient could have. They're all listed in your textbook. But usually the first signs of a brain tumor would be changes in levels of consciousness, brief bouts of confusion, dizziness, and then maybe even seizure activity. If your patient has an acute onset of seizures, we bring them in, we do a full workup to figure out what's going on, if there's a medication that they could have taken that caused them to seize. Like we said before with traumatic brain injury, did they hit their head? We will always do that CT and that MRI to actually visualize the structures and see what's going on in there. Brain tumors can be slow growing. If they're benign, they're typically slow growing, but they can occur in vital areas of the brain, right? So we have areas in our brain that if we had a brain tumor, it could alter our balance. So think of your cerebellum, could alter our vision, think of your occipital lobe, your frontal lobe, think behavior, right? Decision making. Malignant tumors can be more so life-threatening because they grow much quicker. They're much faster growing and they may metastasize somewhere else. Usually brain metastasis occurs when a patient has cancer in another part of a body. Usually brain metastasis will pick up, maybe the patient will come in and they may not know they have cancer at all, but actually they have widespread tumors, and now just because it's metastasized to the brain, they start to have signs and symptoms, neurological symptoms. That being said, your primary brain tumors hardly spread to other areas of the body. They usually just stay in the brain. So these are some types of brain tumors. We can have gliomas or glioblastomas. We can have meningiomas. Meningiomas are typically more slow growing than that of a glioma, which are pretty aggressive. Acoustic neuromas, they usually affect the 8th cranial nerve, which is most responsible for our hearing and balance. And then we can also have pituitary tumors that affect the release of particular hormones. Functioning tumors, so tumors that do affect our hormones, can cause conditions like SIADH, syndrome of inappropriate antidiuretic hormone, or diabetes insipidus. So sometimes your patient will present with one of those. We will do the CT or MRI and find out, oh, you actually have a pituitary tumor. And then we can also have what's called a brain angioma, which is a mass that's composed of a lot of blood vessels. And this could be particularly dangerous if the patient were to have some type of traumatic brain event, like a blunt force trauma or something like that, that would burst those blood vessels. And then we have an active bleed. So like we said, cerebral metastasis is very, very common in patients that already have some type of cancer in another part of the body. This can produce a localized or generalized neurologic symptoms. Usually the patient will present with the signs and symptoms that we discussed before of increased intracranial pressure. So the headache, nausea, vomiting, sensitivity to light. The exploding headache is very common. And then, like we said, nausea, vomiting, fatigue, an altered level of consciousness, maybe even lethargy, and then seizures. Depending on where the tumor is in the brain, we have here, again, a diagram that shows you what each lobe is responsible for. depending on where that brain tumor is, you would suspect to see deficits in whatever area. So if it's your frontal lobe, the patient may have very poor judgment and reasoning. They may constantly repeat themselves over and over again. If you have a tumor in your parietal lobe, the patient is going to have issues with sensations as well as reading and writing. Again, occipital lobe has to do with sight. Your pituitary gland has to do a lot with your release of certain hormones. And then your temporal lobe is usually more so comprehension and language, as well as memory. That being said, if your patient has a tumor within the cerebellum, they're going to have lots of issues with balance. They may be dropping things all of the time. Their fine muscle control is very weak. They're uncoordinated. So your risk factors for brain tumors are like any other risk factors for cancerous tumors, that of exposure to certain chemicals and radiation, as well as the consumption of things that we know that we should not consume, like cigarettes, cigarette smoking, cell phone use, exposure to radiation. And then there are certain genetic components that can predispose someone to brain tumor. There is a condition called neurofibromatosis that can cause patients to have growths not only in their nervous system but all over their body. So our diagnostic tests and treatments for brain tumors are usually that of, depending on whether or not they are benign or malignant, that is up to the oncologist and the neurosurgeon to work together to determine what the best course of action is for a malignant tumor versus a benign tumor that the neurosurgery team can go in and remove without needing chemo or radiation. So we will always do an MRI. We can usually see most tumors on CTs, but we will always follow up with that MRI. We can also do a PET scan, as well as certain studies of the cerebrospinal fluid. As far as medical management goes, we can usually perform surgery pretty safely and have good outcomes. They may need radiation chemotherapy if the lesion is cancerous, if it's malignant, if it's fast growing. If your patient is presenting with increased intracranial pressure, cerebral edema, remember the 4 H's, we will treat them just like we would traumatic brain injury. We will give them those steroids, that Decadron. We will give them gentle fluid volume resuscitation without causing increased intracranial pressure. We will use those osmotic diuretics to pull extra fluid out of the brain. And then in order to prevent seizures, again, we will give them those anti-epileptics. Like Dilantin, Keppra, whatever medications will help prevent another seizure. So what are you going to do for your patient with a brain tumor? Like that of your patient with a traumatic brain injury or even a spinal cord injury, you will always maintain seizure precautions. You will always ensure that you have a suction and oxygen setup ready to go at the bedside. You will prepare the patient for surgery, for surgical decompression if they have a complication like a bleed in their brain, or if they have a tumor that is compressing an area of the brain, or maybe even their brain could possibly herniate. We definitely need to take them for craniotomy, which is where they remove part of the skull and decompress that area, and then they will replace that part of the skull. Your patient may also benefit from a palliative care consultation, whether or not they are at an end of life stage or they have cancer. Anyone can benefit from palliative care. It doesn't matter what kind of patient or what kind of condition that you have. We also will work with PT, OT, and speech, and maybe even get a psychiatry consult. In my experience, patients with brain tumors typically present with a lot of behavioral changes, and even after surgery, after removal of the brain tumor, they may have just complete 180 changes in their mood, affect, and emotional state. It's very important that you assess those changes, and it helps to know your patient before surgery and to know them after. We will always implement those interventions to reduce intracranial pressure whenever possible. We will maintain that therapeutic environment, calm, quiet, cluster our care. That way we aren't overstimulating the patient. We want our head of bed elevated unless contraindicated. Some surgeons after surgery want the patient laying flat. That is up to the surgeon. It depends on the type of surgery that the patient has. Again, you want to maintain really good body mechanics and body alignment. Your patient with a brain tumor, especially one that is post-op, is at risk for delirium. Especially a patient that's in the ICU where there are a lot of machines, there is a lot of external stimuli coming in. We really need to promote reorientation, frequent orientation, so that our patients don't become delirious. If your patient does have a malignant brain tumor that requires chemotherapy or radiation or both, you want to maintain neutropenic precautions, right? You want to wear the appropriate PPE, prevent contact with bodily fluids that are contaminated with radiation or considered radioactive. You may need to limit visitors for this patient who is immunosuppressed. Avoid foods that are too hot or cold, because with that immunosuppression, our skin cells, our mucosal membranes are at risk for breakdown. We want to make sure that if our patient is undergoing brain radiation, that we aren't using harsh soaps or shampoos, conditioners that could irritate the scalp. It's very important that we don't wash off markings in areas where, different laser beams are being aimed at the patient's head. You want to perform meticulous mouth care. Giving them things like nystatin and magic mouthwash can prevent infections. We want to help them conserve their energy as well as promote mobility, while at the same time establishing routine so that they don't become delirious. And that's a really difficult balance to maintain. Again, just like with any immunosuppressed patient, you want to monitor for anemia or leukopenia. Again, if your patient does undergo a craniotomy to remove a brain tumor and then undergoes subsequent chemo and radiation, you need to be performing frequent neuro checks as well as your vital signs. After a craniotomy, usually the patient will stay in the ICU for about 24 hours, and then they can be transferred to an IMC or intermediate care level or a med-surg floor. So as we said before, for patients who have traumatic brain injuries, spinal cord injuries, and brain tumors, there's a lot of collaboration that goes on between you and other members of the healthcare team. I urge you to just think about, the multitude of possibilities there are for these types of patients and how our interventions are so similar for all of them. And that's a great study tool as well. If you know the different interventions that we're going to do for these people, whether it's preventing intracranial pressure from increasing, preventing pressure injuries, preventing contractures, all of those things apply to these patients. So our outcomes for all three of these disease processes, the TBI, the SCI, and our brain tumors, are to maintain our blood pressure, cardiac output, our airway, right, preventing respiratory compromise, maintaining normal ICP levels, keeping those 4 H's at bay. We want to achieve a form of a communication that is appropriate for that patient. So we need to really establish that relationship, establish rapport with that patient and their family. We eventually will need an adequate means of nutrition. The immediate time frame after a traumatic brain injury and a spinal cord injury, as well as preventing seizures in a patient who has a brain tumor, we aren't going to immediately put them on a diet. They may be NPO or nothing by mouth for some time. Do need to provide them a form of nutrition, whether it's through an IV or an NG tube if it's appropriate. Remember, not appropriate if they have some type of skull fracture. We want to limit any post-surgical complications, so remember your interventions to prevent a DVT, a PE, contractures, and then have a plan for discharge. Make sure they understand their medication regimen. Make sure they understand their therapy regimen. Make sure they understand how to prevent complications like neurogenic shock, autonomic dysreflexia, pressure injuries. Make sure they have a good support system, or that they're going to a place that will adequately care for them. So that about wraps up our acute neurological injury lecture. I hope that you all enjoyed this. I really appreciate you dedicating the time to watch this and learn about these disorders. And I hope to be able to help you all in the future. And thank you so much for letting me be a part of your class.